Hello, and welcome to ESOC 2021. My name's Fergus Doubal from the University of Edinburgh, Scotland in the UK, and this is a PI interview where we speak to authors of highly scored abstracts to find out more about their work. I'm delighted today to introduce Alvi, Rahman and Christel Renoux from McGill University, Montreal, Quebec, Canada, who will be telling us more about their work preventing dementia. So welcome.
Thank you.
I suppose my first question is, what are the key findings of your work? What are the headline findings of the work that you bring to the ESOC 2021?
Thank you, Fergus, for the pleasant introduction. So for our study, our main objective was to assess the association between oral anticoagulants and the risk of dementia in patients who have non-valvular atrial fibrillation. In this regard, our main finding was that we found that in these patients, the initiation of oral anticoagulants reduced the risk of dementia by 12%. And this was notable in elderly patients who were defined as those aged 75 years and above. In addition, we also looked at the cumulative duration of OAC use, and we found that a decrease in the risk of dementia was evident within 1 to 2 years of use of oral anticoagulants.
So why is this important? Is this a new finding? Have others found this at all?
So thus far, several studies have shown that atrial fibrillation is associated with both vascular and non-vascular dementia. And as you may know, oral anticoagulants have been recommended for the prevention of stroke in patients with non-valvular atrial fibrillation. However, their role in the prevention of dementia has not been well defined. Previous studies have found inconsistent results. Some have found very strong associations. Some have found weak to no association. And in this regard, our large population-based cohort study provides conclusive evidence of a protective association between oral anticoagulants and dementia in a well-defined population of patients with non-valvular atrial fibrillation.
So you've touched on my next question, which was who was this relevant to? But perhaps you could tell us a little bit more about your method. So who were the patients? How did they get the oral anticoagulants, and how did you perform the statistics to find these findings?
So actually, we take advantage of a large electronic medical record database from the UK, which contains a medical record of more than 15 million patients in more than 700 general practices in the UK, and this practices as representative of the UK in terms of age, sex, and ethnicity. And this database contains medical diagnosis, prescription recorded by the GP. So when the GPs record the prescriptions, they are automatically recorded in the database. So it's a great asset for epidemiology studies such as this one. And they have also record of lifestyle factors such as smoking and alcohol use. And so we use this database and we form the cohort of all patients newly diagnosed with atrial fibrillation at the age of 50 or over. And so we follow them over time and look at their exposure over time to oral anticoagulant, who get diagnosed with dementia or not. I mean, the diagnosis of dementia are pretty well recorded in this database. I mean, very good validity. And we are very familiar with this database in this respect. And so we use special technique in pharmacoepidemiology to record exposure, in a time varying way, to classify patients correctly. And at the end of the day, to as always in pharmacoepidemiology and epidemiology, to compare the risk in patients exposed to patients not exposed, but taking into account in our design and in our analysis the fact that not everybody gets exposed to anticoagulants at the time they're diagnosed, and also the fact that we are not studying an acute outcome, but an outcome such as dementia, who have delays in diagnosis, who can have delays in diagnosis. And so all of that was taken into account in the design and in the analysis of the cohort, obviously.
So it's a nice example of I suppose international work and researchers from one country using a database from another country. So that's pleasing.
Yes. Yeah. Absolutely.
Pleasing to see. You hinted at some of the strengths of your study. What are the key strengths of your study? But also, what are the caveats or the issues that you would worry about from your results?
So in terms of our key strengths, the first I touched upon a little bit. So this was a large population-based study. As I mentioned, it was conducted in a well-defined cohort of patients with non-valvular atrial fibrillation. And ideally, as in pharmacoepidemiology, these patients are representative of those seen in routine practice versus those you might see in trials. And this large population also enabled us to capture many events and conduct a number of subgroup and sensitivity analyses. And just to segue into that, so we conducted numerous sensitivity analyses in our study, which was another strength, I believe. And this was to test the robustness of our findings to the violation of the assumptions that we made. And we found that in all of our sensitivity analyses, which included, for example, taking account missing data, competing risk of death, and different definitions for exposure or and outcome as well. So in all of these cases, we found that the sensitivity analyses were consistent with the primary analysis. And we also conducted a method called the separate analysis. It's called a time conditional propensity score matched analysis. And this is a method typically used to address the potential for confounding, which often comes up in large population-based studies. And we found even that in this analysis, our conclusions were consistent with those in our primary analysis. So we could be more confident that our results are indeed robust to potential residual or unmeasured confounding. In terms of caveats to consider, with our database, it contains oral anticoagulant prescriptions that are prescribed by general practitioners. As a result, there's a potential to miss prescriptions that may be given by specialists. However, in the UK, typically oral anticoagulants are prescribed by general practitioners, so we do believe that this would capture most of the prescriptions. And of course, as in any observational study, you do consider the potential for residual confounding, but we were reassured by the findings from our time conditional propensity score matched analysis.
I suppose working in the UK, I'd agree in that there's a very small private GP market. So most oral anticoagulants are prescribed by the GP, even if they're recommended by tertiary specialist centres. So that's important. All the work we do is obviously patient focused. Does this finding, once it's been fully written up, does this change patient management now? Should we be considering anticoagulants for our patients who are at higher risk of dementia and who have AF? And if it doesn't change our management now, what are the next steps? I suppose both in terms of investigating oral anticoagulants, but also future uses of this type of research, so using large databases. So I suppose the first question first, does it change management? And if not, what's the next steps?
Well, I think, as you say, I mean, you always have to it's always, interesting result, and you have always to think, okay, how does it apply in practice, right? And I think at least what we think that it's certainly, especially in older patients with atrial fibrillation, where we know that even it has been proven that oral anticoagulants, have a huge benefit on the prevention of stroke. We know that oral anticoagulants are still underused, right? Even recent descriptive study in real world population, they show that even in some patients with a clear contraindication to anticoagulants, sometimes they are not prescribed anticoagulant for a perceived high risk of harm or bleeding. And so I think first it's really provide, if needed, a further incentive, to treat patients early and to promote adherence, because we know also there is a problem of not only initiating the treatment, but keeping patients in the long term on oral anticoagulants. So I think it's when discussing with the patient, and even when decided whether to initiate the treatment, I think it provides an additional reason if you wish to initiate oral anticoagulants in this elderly population, and especially in older people, in the elderly, when there is always this discussion about the benefits and the risk of harm. I think now it's in terms of discussion and of the initiation of treatment. I mean, I think it's certainly an additional element to keep in mind, and to when you balance the risk and the benefit and risk of harm in the clinical decision making. So I think in this respect, I think it's important. It's really, the cognitive decline in atrial fibrillation and the risk of dementia. It's something that have been a bit overlooked for many years, but I mean, now everybody beginning to be interested in that. But so I think our results really underline the importance of considering, anticoagulant to prevent this particular outcome, especially because there is no treatment at the moment, right? And we have useful drugs, so it's important to try to use them the best way we can. In terms of future step, obviously, this was the first step, like to ask this really general question: does it have any benefit? But now, of course, with our team, we want to go further and look into potential difference between different class of drug, obviously, and different molecule even. If we can, delineate, the benefit in terms of which drug are best for which type of patient, and does it prevent all type of dementia, and what are the mechanisms involved? I mean, I think there is still a lot to learn on this topic, and it's really for us, it's really the first step, and I think we have a lot to learn still on how to best manage, patient to prevent this outcome, I think.
Brilliant. Thank you very much. So I think it's particularly powerful that it works better in the older patients, because they're the patients that we're often under treating because of worries about concomitant frailty and risks of fall. So I think it's quite a powerful finding there.
Yes, absolutely.
Okay, now I think that's all of my set questions. Is there anything else you'd like to add that we haven't covered as yet?
No, I think just to touch upon your I think you made a comment about what is the place of this sort of large observational study, and I think it's interesting to have this sort of study, not as some people think to replace randomized controlled trial. I think there is really a place for everything, for randomized controlled trial, but also for observational study with large, well-defined cohort in good quality database to look at the effectiveness of drug in the context of daily practice, right? Because sometimes the profile, I mean, we know all that, but sometimes we tend to forget that the profile of patient may differ, and the way they are followed over time, the follow-up is less rigid. You don't have the same adherence, you don't have the same, protective environment, let's say. So and especially for outcome like dementia, where you need a long follow-up, right? And so I think you provide answer over many years that can be very challenging in the context of a trial. So I think it's really complementary to what can be answered with randomized controlled trial.
I think I would agree totally. Absolutely agree. Fantastic. In which case, I will bring this interview to a close. Thank you very much to you both for your fascinating work. I look forward to hearing the reaction it provokes and the discussion at the conference later on this year. Thank you very much.
Thanks to you. Thank you.